Good morning, everyone. It is 9:30, the appointed hour. Welcome to the meeting of the Health Committee for the County of Renfrew. It is Wednesday, May 15th, 9:30 a.m. I'm calling to order. Bear with me one moment. As we gather this morning, I wish to acknowledge on behalf of committee and our community that we meet on traditional territory of the Algonquin Nation. We thank the Algonquin people and express our respect and support for their rich history. We're extremely grateful for their many and continuing displays of friendship. We thank as well all the generations of people who have been careful stewards of these lands for millennia. Ms. Van Starkenburg, has the roll been called, please?
Yes, thank you, Chair, and we have quorum.
Thank you so much. We do have quorum. I would invite disclosure of pecuniary interest, and if there is any, the general nature thereof, please. I see none. The minutes of our meeting held April 10th, 2024 have previously been circulated. I would seek a motion to approve, please. Adopt. Councillor Murphy, seconded by Councillor Purcell. Any errors or omissions? Seeing none, all in favor? That is carried. There were no delegations at the time of mailing. Mr. Kelly, does that continue to be so?
That is still true, sir.
Thank you so much. With that, we'll go directly into the Emergency Services Report. I just wish to note on item 2, there is a presentation. It will be initiated by Chief Nolan, and then Deputy Chief Grenier shall assume the presenter's role. With that, we will go to item number 1 then. The floor is yours, Chief Nolan.
Yeah, thank you, Mr. Chair, and through you to members of the committee. Item number 1 outlines the Treasurer's Report for the Emergency Services Paramedic Service as of March 31st, 2024. That is on page 11, or Appendix ES1 within today's report, Mr. Chair. Would you like me to stop there or continue through, Mr. Chair?
I think that we probably will review all of the information items. However, we will entertain the presentation on the next item, please.
Okay, great, thank you. Thank you, Mr. Chair. So item numbers 2 and 3, and to a degree 4, are all in relation to the MESA program, and we do have a presentation for you for a bit of context as it relates to the MESA program. So, Mr. Chair, I think I will move up to the front just to work through that, and then I'll come back to this position once Mr. Grenier takes the podium.
Absolutely, where you are most comfortable, please.
Great, thank you, Mr. Chair. So I'll introduce Mr. Grenier to you because he's going to continue along with this slide deck. But I think the context in terms of how the MESA program fits into the paramedic service is probably a good place to start so that you understand it in the context of VTAC, 911, and the balance of our programs. And I think that when we think about why the paramedic service has a role as it pertains to mental health addictions and homelessness, which were originally the target populations. We've talked about in this chambers in the past, you know, the significant increases in the number of people who die from opioid use disorder. And last year we're sitting at 39 or 40 of those deaths confirmed related to opioid use disorder here in the county. And that, you know, to put it in a different kind of context, you know, if we had 40 people die in Renfrew County because they didn't wear helmets riding ATVs, there would be a hue and cry. If we had 40 people drown, we would have a hue and cry. So for us, this is no different in that we have people related to opioid use disorder, significant complexities in the drugs that are being supplied through the illegal market, to individuals that are already very vulnerable in terms of addiction, opioid use. Other chemicals are now being mixed in, which is making the clinical experience for the patients and the healthcare system incredibly complex. And I think that that's very important when we think about how paramedics' roles are evolving, both from a prevention perspective vis-a-vis community paramedicine, the VTAC program, going back to Mothers Against Drunk Driving and our community CPR and AED program and the training that we've provided for naloxone. We have a history of trying to get ahead of those things that are going to result in a death, a 911 call, or a chaotic situation for members of our community. So there are those things that have modifiable risk factors, and there are things that have less modifiable risk factors. Certainly addiction is one of those things that have modifiable risk factors, but it's incredibly complex in terms of the social engagement as well as the clinical engagement with people who have been living in states of chaos for a prolonged period of time. And I think it's also important to acknowledge right up front that there are many agencies within the county that have been working in this space for decades to support people in the various funding pots and policy directives that they've received from various levels of government to be able to engage in this population. We often hear we don't have, for example, acute detox programs here in the county of Renfrew, or we don't have enough residential treatment program beds here in the county of Renfrew, or we don't have residential treatment beds for women here in the county of Renfrew. So how is it that we're going to work with that sector to help bring them together to be able to collaborate and share? And whether that's sharing information, as Andrea and her team have been doing for many, many years, or it's how do we actually share resources. And one of the things that I learned early on with the MESA program was different organizations have different allocations of short stay motel funding for many of those organizations have come back and said, we run out of money partway through the year because we have such an increase in demand for people with short stay crisis needs. So this is where Andrea and her team have stepped up to say, wait a minute, how about we pool those resources? How about we understand what your gaps are so that people aren't, otherwise displaced or put back in a position of vulnerability? And that might be addictions, that might be an abusive relationship or intimate partner violence, where not having the money or a safe place to stay is the reason that they're actually staying in those precarious situations. So there's a lot to learn in this space, and I think that it's critically important that as Craig has given us the challenge as the department heads and the warden to say how can we do better with the resources and the mandate that we currently have? How do we do better as a sector to be able to support those other agencies to power up and find other ways of collaborating to support this vulnerable sector? We've seen, even just in the few months of this year, significant waves of behaviors. When checks go out, for example, we tend to have high overdose spikes. We've also learned that that's when people whose interest it is to sell those drugs move in to the community and bring in new drugs, new highs, and new vulnerability for those populations. So we have a pretty good sense of what's going on within that population in that community today. And I think that as we continue to evolve as a service, I think it's important to remember that all of these services, the VTAC program, for example, last year, we heard from over 95,000 patients in Renfrew County who called VTAC looking for service. Almost 75,000 of those 95,000 were seen by a physician in the VTAC program or our community paramedics through the clinics. When you think about it inversely and you think about what's the role of community paramedicine, it's about serving a population that has a historic risk. So it's typically older adults we think about with the community paramedic program who have complex chronic disease, that maybe they're on 5 or more medications, have 2 or more diagnoses, and we know that they've historically been a very high user of the 911 system. Really what we need to start thinking about is what is that, middle to younger aged adult with complex social and clinical disease need to be able to live safely and have an improved quality of life with greater assurance or quality metrics around the social determinants of health. So that's where we're very excited about our role together as Development of Property, Community Services, and the Paramedic Service of leaning into this problem and finding new and innovative ways of being able to support the population. And I think that's fundamentally important from my perspective. We have Basil, who's at the back of the room. Basil is one of the paramedics in the MESA program. So he's one of the early adopters who's put up his hand to say, you know what, I'd really like to work with this population and learn and grow the program based upon the needs of the population. Not what we believe it needs, but by engaging them and understanding this population. This isn't all about homelessness in Pembroke. This is about a significant part of our population that have mental health challenges, addictions challenges, in some cases homelessness, or the rate of precarious housing or homelessness is also significant in the county. And Andrea is our resident expert in understanding the population needs, and she and her staff are getting ahead of that, while Jason and the development of property team are coming up with some innovative solutions to be able to provide better options here in the county based upon the direction that Craig has given us. So I think that that's important context. It's Emily, right? Emily at the back is one of our newest hires. Today's day one for Emily. So in the spirit of how we're managing the program, she's spending her first day with Basil in the MESA program and understanding this population of need. And all of the things that we're doing around that 911 program are to protect those 911 resources for patients with time-sensitive illness and injury that may or may not require transportation to be able to continue their treatment elsewhere. So it's not working in isolation of, it's actually protective of. You think of an avocado and its tough skin, and then its sort of meaty interior is all to protect that pit in the middle. That pit in the middle for us is the 911 program and the critical importance that those paramedics in the ambulance play to protect our most vulnerable, highest needs population, which are typically episodic related issues. Everything else has a modifiable risk factor, and that's where MESA, CPRU, the paramedics who work in the emergency department, right on through to the VTAC program provide better options than ending up as that 1.6% of our patients who need a critical intervention at a time when essentially they've given up the ability to care for themselves. And I think that that's important context. So maybe, Matt, I'll turn it over to you and we'll continue on. Thank you.
Okay, sorry about that. There you go. So thank you very much. Thank you, Chair. So this is the image that Chief Nolan explained to you in terms of we're trying to protect our core activity. So everything that's related to cardiac arrest, to ischemic chest pain. This is the time sensitive that we want to be there and we want to respond on a timely fashion. And when you look at all the other programs that are on us, like our VTAC program, like our community paramedic program, and like our MASA program, is kind of create a protective core around our services to be available to respond to these timely emergency in a timely fashion. If you look at our numbers, it kind of very evident in terms of the emergency, the real emergency are smaller in numbers, but are more sensitive we need to be there in a real time fashion. So we try to protect all the layer, all the lower acuity and the sensitive stuff by other programs that we can protect ourselves with. So I've been working in this program for 2.5 months right now, and I learned so much. It's a different perspective that I gained from all the partners, from Andrea's team, from Jason's team. And I think it's really important that the perspective of that vulnerable population is different than a vulnerable senior. And we need to adapt and we need to think differently how we managing that population. And I'm learning from Basil every day, that from stories that he's telling us and from perspective that he's gaining of interacting with them. So when we start, it was important for us to ingrain, to have a specific objective and vision around this program. So one of the specific goal and objective is establishing a housing first strategy. And I'll talk more about that and why that's really important. And this is Jason, team, and Andrea's team is going to help us to build that. After that is providing the most vulnerable population with a wraparound care across the county of Renfrew. And the third objective is move toward a more coordinated, integrated approach for mental health and addiction and homeless. I know we have a lot of silo. The program, I've been talking with a lot of partners. They're doing a fantastic job, but so silo from funding, from services, and we need to think differently how we approach this as a united front and provide the best service to that community. In terms of goal, we have some short to long-term goal. So the short goal is to mobilize that team that Basil is on right now and providing that harm reduction and that referral pathway and that basic care that these people need to be safe and less vulnerable. To move to a transitional bridge housing model where we can provide, safety in their home and providing care to make sure that they move out of the street and kind of continue their consumer care. And from the long-term care or long-term strategy is going to be to break this silo, to start working together, fill the gap, and provide the anti-stigma training and communication that everybody needs, so we can actually build awareness in the community on what we actually need to build from there. So I know this is really hard to read, but I'll try to go through it so you don't have to squint your eyes too much. But I just took a little bit of time to focus on what we've been doing for the last 2 months. Because I think it's really important for us to demonstrate to you that we're not just waiting, and doing nothing. So last year, I want to start before the red line there. So last year in October, we were talking about the number of deaths that happened last year. So it was 1 every 10 days that somebody was dying in average. So 1 every 10 days. So we need to do something different. So we start working with our GIS partner and our community services, and it was the time of the year that they do a survey to identify the number of people that are homeless or roughly houses or people who were doing couch surfing. And it was a good time for us to identify where people were actually located and sleeping and identify kind of mapping out where they were located for us to be able to respond properly. And roughly at the same time, we need to think about differently. And the Ministry of Health has a new model of care that we can apply for, and they give us the ability for us to think differently about how we treat that population from a 911 system. Instead of arriving and bring them to the hospital directly, we can arrive on site, providing some support and providing new different pathway that we can treat them properly where they are. So we applied for this in February 2024. In February 2026, the County Council approved the MESA strategy, and this is where actually that gave us the approval to move forward. So the same week we put a posting out, and we get a nice team of paramedics who raised their hand and we're quite passionate to get the ball rolling and be on the road. So then March 1st is our first day on the road. And after that, we build a communication plan because we need to be aware of what's going on in the street from all the story we're receiving from our team, communicate that to public health, communicate that to us and to our team and to our paramedic and to our dispatch so we know what's going on in the community. So we built somewhat of a channel where we exchange information back and forth, so we're all aware of what's going on a daily basis. The OPP has a team they call MCERT as a mental health, so we partner with them. We were doing some foot patrol. So the first foot patrol was March 13, and we're doing the same thing over and over with them to build a more synergic approach between the two teams. And after that, we talked to the OHT. So the OHT is the umbrella from a health system perspective. Let's say this is a crisis. This is something that we need to actually advocate for. So with JAMA, who's the lead of our OHT in the county, we build a table with all the core partners from mental health services, addiction services, OPP, community services, housing, us, name it. We have a table of 20 people that are meeting on a regular basis to think about strategy and how can we actually work together to move this forward. At the same time, we establish an evaluation framework. So when we talk to our partner, not a lot of people were actually collecting data and evaluating their performance the same way that we do from a 911 perspective. So we start collecting that information, and this is what we shared with you last month. So where everything that we do is collected, so we can actually build a strong evaluation framework that we can present to you at the end of the year, and just to show performance and show the actually impact that we have on the community. And after that, we on May 27, a month after their approval, we have our first contract with our mental health services from PRH. This is our first team that's going to have a service attached to us that we can respond to any mental health services or mental health crisis in the community. So that's been going on, on a regular basis, and we have a 1-844 or 1-800 number that we can connect them with 24/7. And we're starting to build a relationship, build these clinical pathways, so we can actually refer these people on that need that service instead of bringing them to the hospital directly. And after that, April 4th, it was a big housing event. I think that was the first big celebration for housing, informing all our partners that we need to change the way we think about housing. And that was a great event and a lot of participation. We work on April 18 with GIS and all our partners around the OH table around mapping all our assets. So it's important to know that we have a lot of service in the community. But when you're working in Pembroke or working in Pembroke, you not necessarily know what's available and how to connect with them, how to refer, and what's the capacity. So we're building with our partner to build that asset map. And their goal with that is creating an app that everybody can have access. Say, okay, I'm in Pembroke, I need food for that gentleman. What's my resource? Who I need to call? So if everybody would have that on their fingertip, it would create a lot of efficiency and a lot of better services to a vulnerable population. April 19, the shelter closed their door. So that week we kind of tried to figure out what can we do, because now everybody was going to the shelter, that warming center, to sleep. So we knew where everybody was. Now they're kind of scattered all over Pembroke again. So it was important for us to identify that, and we work again with our GIS team to start mapping out and get connection with these people, to just knowing where they're sleeping, if they're safe, if they're in community or if they're by themselves, so we can interact with them and kind of engage them where they are. And after that, we received in April 23rd our MOH approval for that new model of care. So this is where we're going to work in terms of creating this pathway, so we don't need to transport these patients to the hospital. So that's a work in progress, and we hope to have this ball rolling soon. In April 24th, we get our addiction services and community withdrawal services approval from County Council. So they're starting next week with us and team in Renfrew. So that's going to get another partnership where we can build pathway and resource to help with addiction services. We are the MESA coordinator in May 3rd, and this is where that coordinator will be able to accelerate our process and again move forward a little bit faster. On April 29th to May 5th, we realized that every first of the month, and I think our chief talked about it, people are receiving a check, and they have an addiction problem, and they often use the drug that's coming from all over the province, and the drug is not safe right now. So what we try to do based on our data is we see a higher level of overdose and higher level of death in the first week of the month. So how can we surge? How can we have a better communication bring some services in the Pembroke area where people are to make sure that we don't have these debt every month in the first week of the month. So this month was successful. We have no debt. We have some overdose, but it was well managed by our team, by airway management and good medical care. We have our second team starting next week. We're starting to build a partnership with the Rural Ottawa for a RAM program. A RAM program is a rapid access to addiction medicine clinic. And this what gives us is drug substitute therapy. So people are taking Suboxone. I don't know if people heard of that. Is a substitution therapy that instead of being addicted and being in withdrawal, you get that medication so you don't have the same urge to use. So you can actually start talking with them on the other option and kind of provide care around it. And May 22nd is going to be our MESA event. Everybody's invited. We're more than 100 people registered already, a lot of excitement in the population, and I think that's going to be a great day. Okay, so this is the big story, what happened. In terms of data, since March 1st, we have over 250 encounter and interaction with our client, mostly in Pembroke. This is where our team is located right now. Mostly with people with mental health addiction and homeless. And we have 4 big buckets in terms of community outreach, support from a 911 or a 911 diversion, some wellness check, and some clinical intervention. And every number that you see on the screen there, it is a person and is a story and is an intervention. So these numbers are big in nature, but just imagine every day Basil and his team are doing a lot of work to make this population less vulnerable. Okay, I want to jump into the housing piece, and this is maybe more adjacent subject here, but we have a lot of challenge in that region from the warming center that address a lot of that immediate need to socializing and the wait list that we have in our county. So just look at the number of people who use our warming center. So 100 people use our shelter this winter. In terms of hotel motel, we have more than 500 people who use that hotel last year. And we have a lot of rent adjustments, just make sure that people can afford to stay where they are. And we have 1,100 people who stay in our social housing. And we have 1,000 people waiting on a waiting list to access our social housing. So that in itself is our challenge. And this is where I think Housing First is a strategy, because without a roof overhead, you lack that basic need of being able to pursue in life. And what's interesting with MESA is a multi-departmental aspect. And working with Andrea and Jason, they bring so much value into that sphere, like from onto work or case management or childcare services. They bring so much value into the interaction we have in the community. And I'll demonstrate some of the examples shortly. And from a primary services, we have the 911, and now with the new model care, we'll be able to intervene differently. We have a VTAC with our VTAC physician for clinical intervention. The MESA team is the outreach piece, boot on the ground, that interact day to day with that population. Our CPR program is more the assisted navigation and referral pathway. And from a housing perspective, from a development and property, make sure all our buildings are safe and in order to build some bridge and supportive housing to have these independent living housing that we can actually offer to our population. So just kind of in terms of our program, Nut and Boat is we're working 7 days a week, 12-hour shift, 9 to 9. And the 9 to 9 is when we look at our data, this is where the need was, and we'll readjust if the need be. But this is where we're actually making the most money for our bucks to be supportive for that population. So we have 2 teams. The first team is in Pembroke with mental health services, and the second team is going to start next week with community withdrawal services. And we have also ATS going to be supportive from addiction services to be able to continue that care pathway from addiction services. And we look at this program in 4 pillars. So the treatment and referral, this is with our clinical assessment center, this is with our VTAC physician, this is with our CPRU, be able to make some treatment, some clinical and referral to service, like mental health, like addiction services, like any community services that Andrea's team is bringing to us. From our harm reduction and education, we're working with public health to make sure that we have good education. And I'll show a couple highlight an example of what's been successful. And the anti-stigma is something that we really need to focus on and work on in the county. And this is work that we need to work with public health and really bolster our communication plan in that regard. And then from our housing and community services, they bring so much value to that community, and we interact with them on a regular basis. And is thank you for this, Jason and Andrea. So every person has a story, and I think if I ask Basil, he could probably tell me 1,000,000 stories from what he. And I think what's important is when you see a post on social media, and it's like not in my backyard kind of language. I think the importance is to understand is everybody has a story. Everybody has a perspective and a reason why they're struggling. And taking the time to listen and advocate for that person will make a community better. And I'm just going to finish my presentation with a couple highlight or success story. Then us just intervening and bringing them to a journey has created a huge opportunity for these people. So this gentleman came to us with a wound care, all affected, and he was suffering from some mental health and some addiction. But he was really adamant that he wanted to find a job, like he wanted to get out of the street. So we talked with our paramedic, we brought him to the assessment center, we cleaned the wound, we called our physician to get some antibiotic, we showed him how to take care of the wound, we put a bandage in properly. And when we had the conversation with them and say like, I want to, be more productive, I want to get a job, so we connect with social housing and we get a motel for 4 nights. So that gentleman was able to clean himself, clean his wound, and also they have a service that they help that gentleman to build a resume for himself and apply for a job. So he applied for a job, he got a job, and now we have asked social housing to get a couple more nights, so until he starts working. So now that person is actually working. And it's just because we took the time to listen to that person and be able to help him, get to the right path. So in terms of harm reduction piece is we're distributing Narcan a ton. But this story is kind of the impact of this interaction and engagement. So one of our paramedic got told, hey, good bless you there, and thank you for all your service you're doing. With the Narcan kit that you gave me last week, I was able to save somebody from overdosing. And the paramedics say, thank you very much, and thank you for your help, and thank you for being courageous and be able to do that. But these are the type of intervention, and this picture is Paul is a prime example of a person like that the harm reduction is from peer to peer, and having a Narcan kit available when somebody is using, it can save a life and can make a difference between life and death. So this is just an example, a story, again, a success story, and I'm pretty sure that happens every day, we just don't hear about it. And the other piece of story from a crew is, so 911 diversion. So when the Mazda team arrived before or at the same time ever a 911 crew, what we're trying to do is to divert or ask the 911 crew to go back on service. And the reason for that is the core we try to protect, our core for another emergency, for an time-sensitive call. And at the same time, it take the opportunity for the team to actually sit down and have a conversation with that person. And asking them about their living condition, asking them about their mental health status or their addiction status, and try to figure out how can we support them. And sometimes it's just, that 15, 20 minutes that you spend with that person will make a difference. And it's that relationship that you build that will translate to other relationships that you can build in the community. And the last harm reduction piece that we have is we're not going to stop people from using drugs. That's maybe a future state, but it's not happening anytime soon. But one really important harm reduction is to use with somebody and use safely. And people are in community, and usually they can support each other. We're also promoting an app called Lifeguard, where people can use with that app that we have a live person on the end, and they're talking to each other. But using with another person, using with an app, make the difference between us finding that person dead the next day, or that person can get recessed or call 911 if they need from a overdose perspective. And I'm just going to finish with a question is, how can we all contribute to make this community better? And I think we all have a role as a community to just take the time to talk with each other and be respectful and treat these people like they're your neighbor, and listening to them, and this way you can actually make a difference in their journey. Thank you very much.
Thank you very much, Deputy Chief. A very, very interesting presentation. We will come back to item 2 when we are doing review of the information items, so hold your questions, comments for now. With that, I would return, Chief, to, so I believe that the intent is that encompassing several of the numbered items? You pick it up where appropriate then, please.
Good, thank you, Mr. Chair. So items number 2, number 3, and number 4 have been touched on within the presentation. The only highlight that I would make is if you have not yet registered for the Mesa gathering, please do so, because we do have a cap on the number of seats available, and we're nearing that cap now. So please do sign up for that. You can access that either through our social media channels or through the county website, or I have a QR code that you can scan before you leave today that's available as well. Item number 4, Mr. Chair, is the treat and refer model. And just to highlight that, going back to last fall, we did anticipate opportunities to better manage people experiencing mental health crises and addictions-related issues. And in many circumstances, there's an aversion by some of these clients to go to hospital or to be in care or to be in sort of an institutional framework. So the approvals that we received from the province really were, thank you, Craig, really were aimed at allowing the paramedics and supporting the paramedics to treat these individuals and not have to take them to hospital. And as we build out alternate care pathways, we have potentially other places where these people could go other than the hospital as well. And I think that's important. And the RAM clinic that Matthew talked about, is an outreach program directly from the Royal Ottawa Hospital, so the experts in providing this care. And just last year during the pandemic, they extended what was a walk-in program to now a virtual program. So we're engaging directly with them and their expertise in mental health and acute care services. So a big thank you to the Royal Ottawa Hospital. Item number 5, Mr. Chair, and for those that like numbers, we've tried to satisfy their appetite in relation to both the IVC program and the VTAC program. And just as a reminder, the VTAC program has an arm. So VTAC is episodic layered primary care, where the VTAC program allows us to work with local family health teams who have vacancies within their own physician complement. And what VTAC does is provide some seed funding to be able to onboard patients who do not have a family doctor to a virtual doctor who works, for example, for the Petawawa Centennial Family Health Team. So that doctor can then refer people into the allied health, occupational therapy, and so on within that family health team, because the doctor is part of the family health team but is working virtually often from elsewhere in the province. And I think that this is a very innovative program that we often don't highlight enough. And we have partnerships with the Petawawa Centennial Family Health, West Champlain, and North Renfrew Family Health Team. And based upon a recent satisfaction survey, 87% of respondents said they were very satisfied or satisfied with the enrollment process. And we're very happy to show you the statistics on the next page as well, because when we look at January, February, March for 2024, the first block of numbers are related to the VTAC program. So in March, for example, we had 5,621 people contact VTAC, as I had referred to sort of in our grossed up annualized numbers, but those resulted in 3,210 physician booked appointments, which show an obvious demand for the services. And of that, 352 people were seen by paramedics in our clinical assessment centers across the county. So that gives you a bit of a snapshot. But the IVC numbers in the second table tell a different story. And these are the number of patients who are now permanently attached. So they now have a named family doctor. They're no longer unattached. They're permanently attached. And as a running total, we're from October until March of this year, we have 6,235 patients now have a family doctor in Renfrew County that didn't previously. And we do work with the experience that we have in the VTAC program to identify people of the greatest need who have geographic relationship to those family health teams that were listed within the report. So what does that look like? We're looking at about 107 new patients just in March alone that were enrolled in that program. So again, as physicians retire, as people become orphaned, as people move to the county, we're continually kind of swimming upstream in this current of trying to catch not only people, but the right people to get them attached so that they're not going to result in a VTAC phone call. They're not going to result in a 911 call or a hospitalization, right? They have stability in their care and they have some reliability with their named primary care provider. And then the number of completed appointments of 24,529. That's a pretty impressive number when you look at it in terms of the number of patients that are being managed as an extension of our VTAC program. So again, a big thank you to the province and a big thank you to Committee and Council and the City of Pembroke for their support in these programs, because they're making an obvious difference in the access to care in our community. And I don't think that anyone needs further convincing of that, other than maybe some policy folks at the province that are always trying to look at other parts of the system and how does this compare in cost and how does this compare to downtown Toronto. Well, the reality is we have a significant number of people that are now permanently attached because of VTAC and the IVC program, and a big thank you to Judy Hill and her team for leading that subcontract of the VTAC program for us. And then secondly, all the great work that the physicians, the medical receptionists, the paramedics are doing within the VTAC program itself. And when we compare ourselves, we know that the VTAC program alone reduces ED and 911 calls by over 15,000 a year across Renfrew County, just because we're working far enough upstream that we're reducing those downstream impacts. And we have all of the research to back that up, and you'll see in number 8 we've just published again as it relates to this program. Item number 6, Mr. Chair, a big thank you to Fred Blackstein for allowing his street to be renamed, and a thank you to the City of Pembroke for Fred Blackstein Way to now be recognized as First Responders Way, and that's the first in Canada. Fred was incredibly proud to be able to offer his named street to first responders, and as you know, Fred has led volunteer search and rescue, has been an incredible influence on our Sierra team and its development, and drives around the county with an AED in his Jeep every day in hopes that he's in the right place at the right time to be able to support his neighbors and people that he's never met before. So a big thank you to Fred for everything that he does in our community, and a special thanks for recognizing the first responders in the way that he has. Item number 7, the rehab facility resolution to the province of Ontario. So in ES4, there are resolutions from the City of Pembroke and Town Laurentian Hills to the Honourable Doug Ford, Premier of Ontario, requesting the province allocate funding for the establishment of a mental health addictions treatment residential drug treatment facility serving Renfrew County. This resolution is being presented to Andrea and her committee, the Community Services Committee, with a recommendation to support. So this is for your information. Item number 8 in research, so again, connected to number 5, Ms. Judy Hill, Executive Director, and Dr. Fitzsimon, Medical Lead for the Petawawa Centennial Family Health Centre, recently published in the Canadian Journal of Rural Medicine an article entitled Assessing New Patient Attachment to an Integrated Virtual Care Program in Rural Primary Care. So a big thank you to them and the entire team that supports all of that work. And this is part of our recipe of not just doing what we do, but also evaluating what we do and publishing what we do so that it's able to be spread and scoped and scaled across the province, because we know that we've got a good thing for our communities, and there are many communities now, as you've seen locally in provincial media at least, that there are now millions of people who are becoming unattached, and we have a solution that if the province chooses, we are happy to replicate and support other parts of the province to adopt their own BTAC and IVC models. Item B in number 8 is the Penthrox study, and the Penthrox study is a regional program that we've been working with the Base Hospital program, and Penthrox is an inhaled analgesic. So you might remember laughing gas from a long time ago. Well, Penthrox, and it's a crude equivalent, but it comes in a whistle type format, so it's something that you as the patient breathe in yourself, and it provides you an analgesic inhaled, typically for short-term pain relief for conscious people, because you have to be able to manage it yourself. But if you think of the pain of a long bone fracture, you fractured your femur, for example, well, this is a near immediate way of providing you some relief from that pain, and is highly effective. It's been used all over the world by paramedics for a long time. Ontario's just catching on, so we're just doing this Penthrox study to move it forward as part of regular paramedic practice. So we're pleased to help, again, move that along, and really proud of the paramedics for doing the online training associated with that, so that we can give our patients the best care possible at this time. Item number 9 is the Guardian Angel nomination, and a big kudos to both Aaron O'Reilly-Olszewski and Wade McPherson, both paramedics who've worked directly with the Madawaska Valley Hospice, and they accepted a nomination on behalf of the service for the care that they provided. So big thank you to St. Francis Valley Health Foundation and the Guardian Angel nomination. So kudos to them for their outstanding work. Item number 10, Mr. Chair, is moving into resolutions.
I think we'll review the information items before we get into the resolutions, Chief, so thank you. And committee, if you return to page 6, information item number 1 is the Treasurer's Report for Emergency Services. Any questions, comments? And I believe that can be found on page 11. I'm just kind of curious, and Chief, through your, if you wish to defer to Mr. Burke, so there is substantial underspend in the top 4 lines, which are both administrative and paramedic salaries and benefits. The savings are just under 1.8 million, or almost 29% under budget. I'm wondering, is that a function of the calendar, i.e., is the full year budget disproportionately allocated across different quarters or anticipated to be across different quarters? Or are we seeing substantial savings? Because those are incredible savings at 29%.
Thank you, Chair, and good morning, committee. The savings, I would suggest, are not to do with the, well, per se, to do with the budget allocation, but rather, committee will recall that a significant portion of the MESA program's staffing costs are contained within these lines. The admin lines would contain the, when we budgeted, we talked about crisis workers, 12-hour days for crisis workers, and then the paramedic lines would also be the east and west teams that we budgeted to have a paramedic on the road 7 days a week, 12 hours a day. And I think that the issue is that those programs, as we heard this morning, are just starting up now in the April, May type of area, and we're not onboarded on January the 1st.
Okay, that makes eminent sense to me. The only other question or comment, I guess, that I have, those 3 columns on the left, are we piloting a new template? The monthly information?
Apologies. Through you, Chair, no, they always exist on the Excel version of the report. Normally, we do not include them in the printed committee report, but no, they should not be on display there.
Well, you know, going back to the Chief's earlier commentation, who doesn't love numbers? In any event, that is all that I have. Moving on then to item number 2, which was the, and once again, we will combine several of these items that are also consistent with the presentation. Questions, comments? I'll begin with Councillor Lafreniere, then Councillor Weir, then Councillor Murphy.
Thank you. First of all, thank you for that wonderful presentation. I loved the analogy that Chief Nolan used, comparing other highly fatal events that can happen in a community and how we respond. And the opiate epidemic and the homelessness problem is another one that we, you know, comparing the two and the way that we look at them is quite an eye-opener. The stigma that can be attached to one rather than the other. Also, the line, every person does have a story. And this is something I'm having trouble dealing with right now as a Pembroke councillor, is there is still a lot of unawareness. They're not educated about what the drug situation is doing to these individuals. They're fearful. So as you know, we have the Grind located in Pembroke, which is a wonderful service, but we do have some issues with some individuals that are fearful. And I think the education component is so important to the residents that live in those neighborhoods. And I think that's missing right now from my standpoint, because when I look at these videos on social media of these individuals that are suffering and they're being, you know, mocked or treated like they are a real threat, when really they're hurting themselves more than anyone. And sometimes, as you said, just giving them a hello or are you okay, it means the world to them. Maybe they don't act like, they don't look like they're even listening, but I guess I'm having a real problem with that personally. And I have to try to separate myself from my understanding of what they're going through and others' lack of knowledge, and I'll call it that. One thing we are facing in the city, and I'm just wondering what your take on this is, the encampments. So, you know, we have a tent here and a tent here, and you are doing really well in finding these individuals. And now that the trees are growing, it's harder and harder to see these tents. We are having a problem in the city as well, where we are having them in areas where we don't really want them. And when we move them, we have a large problem of cleanup, which that's not the issue I'm bringing up to you, because that's not your responsibility. But would it be beneficial if we did have designated areas where okay, you can have 2 tents here, you can have 3 here, because right now they're just popping up everywhere, which is causing a problem. And I know from a city perspective, it's causing a lot of stress on staff. They're finding, needles, pipes, whatever they're finding. So would it be beneficial? Because I know right now the plan is that if they're in an area we don't want them, we're going to pack them up and bring the tent and all of the personal items to the grind. And when I heard that plan, I was just like, oh boy, that's personal items. And the grind has nowhere, they're just going to give it back to them and say, go find a place to sleep. So it's kind of we need to work together on a plan. And so I guess that's my comment, is I would love to see designation so that the grind, they're just trying to do the best they can too, so that they can say, okay, I know that there's room for 1 here. I don't want to see 100 tents set up in a field, but some kind of coordination. And I know we'll always have the odd one popping up, but maybe it would help everyone involved.
Yeah, thank you, Mr. Chair, and thank you, Councillor, for the comments. And I'm going to make an inference in terms of what the question is. But I do want to remind people that item 2 today was really about anti-stigmatization, right? And I'd say anti-stigmatization starts with education and an understanding. And if it can end with some degree of empathy or compassion, I think we've moved the needle. So the May 22nd event is about bringing in experts in destigmatization to talk to any of the stakeholders and anyone from the public that comes to better understand the origins of mental health, addictions, poverty, and really the full scope of things that are a day-to-day challenge confronting this population in a way that we hope that we can simply provide them better options, right? This is about creating choices and then helping guide people towards better choices when we know that if you've got an opioid use disorder, that quite literally your brain is rewiring itself because of your exposure to toxins. And people need to remember that. And for those that have a child that has a use disorder, and they think of them as a child and they think of them as an adult, and something changed in the middle, the drugs that are now in circulation are designed to change your brain. Right, in the 80s, when slot machines were all the rage, and everybody's like, "What do you mean that sound is calibrated to encourage you to do something?" And the colors and the noises and the experience are all designed to make you do something. The drugs are designed to make you want more drug and make other things in your life less of a priority, such as caring for yourself. And when people are self-medicating because of trauma, then that becomes a very cyclical process that lands people in a very precarious situation. And of the 40 or so people that died last year in our community, 1 every 10 days, as Matthew puts it, that's very different than suicide, right? That's very different than an intent. That's about self-medicating in a very unregulated way that has landed people in a very desperate situation, not being able to breathe, not being able to care for themselves. So that's the first component of the destigmatization that I think is important, that the May 22nd event is all about. Bringing experts and bringing in the experts within our own community to have a World Cafe event where everyone can share those experiences and those lenses, and hopefully there will be some discourse. Hopefully we don't agree on everything, because I think we all have something to learn as part of the process. When we think about our role as the county, as a paramedic service, we have a lens that we've described today. Andrea's expertise within her department is phenomenal. Jason's efforts towards supporting the housing component and the development component and the economy are undeniable. And with the CAO and the warden, we're really starting to pull this together to get the right people to the table to have the crucial conversation. For today's purposes, the grind and its role, from my perspective, is a critically important one because it provides a service that isn't otherwise available. How that is defined what the city's or the county's relationship is with the grind is best suited for probably another conversation. But as far as we're concerned, being able to provide people food where food is not otherwise available is important. Provide people access to Ontario Works caseworkers at the grind is one of the services. One of the physicians in the county provides time to the people at the grind. That's a service that's provided. The community paramedics are in and out of there every day because it's an easy way to be able to have FaceTime with these people. So it's because we have FaceTime with these people that we know where they're living, leaves or not, because we're having a conversation saying, where are you guys hanging out? Is there anything you need? And the community paramedics themselves have provided garbage containers and sharps containers to those individuals so they can take their sharps and put it in their own sharps container and leave it in a place where it can be picked up or dropped off. There is a desire amongst the majority of the population to take care of themselves. They just don't have the resources or the guidance to be able to do it in a way that I think will solve some of your downstream comments about the cleanup or the this or the that. I think the issue of displacement is a very delicate one. I think when you look at it from a legal lens, you can look to Kingston, Belleville, Toronto, and other jurisdictions who have gone the eviction route and been told you can't, have gone, through the clinical or social lens to be able to, how do we engage with people and not over-stigmatize them by simply continuing to create poorer and poorer options. The amount of criminality within that population is stark, and it's something that the staff on a day-to-day basis are reminding us of. When you are high or when you're going through detox and you've chosen to no longer be under the influence, that is your greatest point of vulnerability in your day. You're likely to be robbed or raped in that period of time, and that's occurring in our community every day right now. So we can't forget that these are the adversities that these people have, they're encamped in a particular area. I'll leave that to the property owners and governments as to how they choose to exert their rights. But at the same time, I think we need to be very conscious and cautious that every action may have an unintended consequence that actually worsens the situation. So I would encourage continued dialogue, and I know the warden and CAO are part of those conversations on the regular. But I think you're right, it does need to have a strategy, and it needs to be very considered, whether it's on private property, city property, county property, or provincial property for that matter. So maybe I'll leave it there for you, Councillor.
Thank you. Councillor Weir, please.
Thank you. Through you, Chair. On Friday, May 3rd, I had the opportunity to go for a ride-along with Chief Nolan. In that ride-along, we came across a lot of people, and I just want to impress upon you the dedication Chief Nolan has. Everybody we stopped to talk to, he had them by first name. The rapport he had with them, the openness of communication, them talking about their journey through the addiction and where they are now with us was very open and honest. We also had a chance to, on that day, they had a meeting with all the community partners for the MESA, and that was, I think there was approximately 30 people, including staff there, and it was very informative about new initiatives they're taking on, so that was very good. And then I had the opportunity to sit with Basil at the grind. This is something that's been in, I guess, 2.5 months now since Basil, you came on board, I believe. The openness, the honesty, the transparency that everybody had with Basil, it was like a family. They were open to him. They were talking about their problems, their issues. And because I was sitting beside Basil, they had no trepidation about talking in front of me because I was sitting with Basil. After that, at the grind, I had a few of the clients want to take me for a walk and show me what they called the bad areas. So I went with them. We walked for, I guess, about 2 hours, walking and talking. And these are all people. These are all real people that have gone through a lot. And I think that's something that we need to bring home. And I just want to commend Chief Nolan and his entire staff on what they're doing. And it's a very personal thing to them. And as I say, just the openness of everybody was wonderful, and it was great for me to meet and go for walks and just talk with people. So I would encourage anybody that gets the opportunity to do that to take it up. Thank you.
Sorry, thank you very much, Councillor Weir. Councillor Murphy, please.
Thank you, Chair. I'm just wondering if people said to Basil, why'd you bring the cop with you? Since we're blending these two things, one of the things in Matt's presentation was about our partnership with PRH. I'm just wondering if PRH even has the staffing and the funding to really make a huge difference, because I think the ask of a dedicated mental health and addiction facility is of the utmost importance, and it has to be passed by every local tier in the county of Renfrew. But I do worry about how much resources PRH actually has. My second thing is the Mesa gathering. My QR code wouldn't work, and I didn't write down fast enough where you told me to find how to register. I think I could only go for most of the morning, but I would really like to be there, but I couldn't register. Thank you.
For those who are paying attention at home, there is a conversation happening out in the council chamber that you probably can't hear, and I think perhaps we can take that one offline. Are there any more questions or comments on the presentation or any of the numbered items that are before us? Warden Nemo, please.
Thank you, and I think this approach demonstrates what we've talked about for a number of years. And I take you back to 2000-ish, 2008 or 9, I believe, when we started with the community paramedicine program in Deep River. And the idea at that point was very broad in the sense that we have extremely competent, highly trained people who at that time we were underutilizing. And the idea was that we wanted to get more value from them, and they wanted to give more value. And so this has been a steady progression based on research from the paramedic service, based on research and on-the-ground intelligence from Renfrew County Housing Corporation, from the Child Care Division, and from Ontario Works. And then also from Development and Property side, because they manage the facility. And so it's a response to a community need, and the community need has to be individualized at the same time as we provide group care. The individual touch and the knowledge, and as we said, I think 8 or 9 months ago when we first started talking about Mesa, was that as soon as you're able to establish a rapport and show caring and demonstrate an awareness of a person's need for good health, and the paramedics are able to do that. They can listen to someone, make a concrete suggestion about a treatment venue, whether it's wound care or whether it's something else. It may even be high cholesterol that their grandfather and their father has had, and it really scares them and they haven't had it addressed. So it's as basic as providing a personal touch, but at the same time providing the foundation of caring for their health. And then they can start, based on that foundation of trust, following the direction into the system to make some improvements. So I was really glad to see the example, because that's the perfect example of the person who had wound care and then got assistance with his resume to make application for a job, and Renfrew County Housing and Ontario Works supported that, and that's the proper care model for someone. And they can probably, they'll continue with him as he progresses. So I think, we've got some really good examples. We've got a model now that is starting to support the community. We're moving, as you'll hear, at some point towards a transitional housing model as well, which will then meet another segment. It takes time to assemble all these pieces, and it takes time to as you grow trust with the clients, we also have to grow trust and relationships with the other service providers. So to the chambers and the community, thank you for your patience as this is slowly rolled out. The Chief Nolan has worked very well with Ms. Patrick and Mr. Davis, but also with with the CAO, Mr. Kelly, in terms of refining the vision, and then also understanding the community. And I think the warming center experience for us was a critical decision by council to get involved and show immediate concern, but at the same time, it also allowed us a doorway into a different model. So just, this is a great approach. It's been a team approach. There's been a political element to it, which the chair has been involved in, and other members of county council and our friends at the city of Pembroke, as well as an on the ground and a planning. So thank you to everybody. It's working. We'll be growing the model as it moves along. It's nice to see the collaboration and the tie into RCVTAC. Again, that was a critical pillar, and our partnership with RCDHU in terms of harm reduction, and I think there'll be other partnerships with them as well. So it's moving along. Some say too slowly, but I think it's almost lightning speed for how governments have had to break down silos in the past.
Thank you, Warden Emo. Anything further, committee? Just as final comments, I was very pleased both in your introductory remarks, Chief, and then ultimately Deputy Chief Grenier had a photo of his was more of a spherical avocado. But nonetheless, it has occurred to me, and I know even in 2023, when the decision was made for the first expansion to the paramedic service, the first new 24-hour car that we discussed, most, if not all, of the initiatives that we have been seeing within the paramedic service have brought incredible value to our community, but they have been predicated upon indemnifying the 911 or legacy system. The paramedic service has been for a long time the canary in the coal mine that is the first to see the cracks and the breaks within our health system. Because ultimately, when someone doesn't have a known path, a known avenue available to them, it is 911. As 911 is beginning to increase repeatedly over all of these years, a very careful analysis of the data that Deputy Chief Grenier was speaking so directly to has yielded substantial results right across the community paramedics, which is now in long-term care. It was in the vaccine program. It is now now it is in long-term care as well, but the VTAC is also a portion of that. All of these, the foundation of these was to try and indemnify the emergent response that is required of our paramedic service. Likewise, MESA is the same thing. As the warden had suggested, I am very, very pleased to see at least the nascent steps towards reducing the silos, the rigidity of our responses. We know even within the MESA, we've had to bring together both housing, development and property, and the paramedic service. I know in conversations at Roma, the provincial government has to jerry-rig some specific responses because this issue doesn't neatly dovetail into one ministry's responsibilities. So we are having to respond in the moment. So I'm very pleased, as the warden had suggested, it is not moving fast enough for some, but it is the speed of light in terms of how government responds. And I think that we typically, the MO, the modus operandi has been to observe for some point, but then at some point stop observing, roll up the sleeves and dive in. And I'm inordinately pleased that this MESA is the result of this. How this evolves, what MESA may look like in 5 years and 10 years, I don't know, but I think we now have the core that is going to be able to meet this because this is going to be a whole of society response. Mr. Kelly, I believe you have a comment.
Thank you, Chair. And again, I applaud those involved with MESA. It's really rolling out quite extensively and we're starting to see some success, so thank you. But on your point on finding the funding envelope, I'm not going to get too far into advocacy because we are working on getting to meet with the different ministries later this month. However, I'll note that there is a path forward for funding. It has been recently announced in Lambton County, in Thunder Bay, and in Simcoe County, funding to stand up Mesa-like teams, otherwise known as mobile response crisis units, under funding for mental health and advocacy. They are about to embark on a pilot, and I would say to the people of the province, quite honestly, that we've stood it up and it's working. And we need that funding to showcase the East as much as it's being showcased in the Central, North, and West. And I think that's a key point, that there is a funding envelope. And quite honestly, Renfrew County deserves a share to show that we can do this just as well as other municipalities can do it.
How prescient of you, Mr. Kelly. That I was going to raise that comment for item number 10. I think that one was perhaps omitted from the possibilities of delegation status. With that, then, bear with me one moment. So I'm going to pick up at number 4, the treat and refer model of care. Questions, comments? Item 5, RC VTAC. Councillor Nicholson, please.
Thank you, Chair. Just a quick one on the IVC numbers that we're seeing, a total of 6,200 new permanently attached patients. I'm curious, we've heard numbers between 25 and 30,000 members of the Renfrew County being unattached. Does that 6,000 reduce that number, or is it just allowing that number not to grow, or is it some proportion in between that? Can we offer any comment on that?
Just prior to inviting Chief Nolan to respond, I'm not, and if you could respond to this first, so in the second column, I don't know what is the nature of the October 2023 number of 3,100, but just on the new patients enrolled between October through to March, there's 3,000 new, and based on the last number that I saw of unattached of 30,000, that's 10%, and that's incredible over the span of 6 months. But I would yield, certainly, Chief, perhaps you can add more flesh to the bone.
Yeah, thank you, Mr. Chair. So the patients within the IVC program who have been attached to a named physician do come off of the wait list that you would otherwise be quoting. The challenge with the wait list is that it's continuously growing while we're chipping away at the bottom of it. So as physicians that have long-standing practices and have thousands of patients retire, that list comes down, that list goes up. So it's quite tidal. Our goal is to continue to chase and make available more spaces within the IVC program, and to work with existing physicians and family health teams to continue to increase their rosters at the same size. But we are still sitting sort of, I call it 25,000 plus or minus 5 at any given time, depending on how many we're rostering in IVC, how many are being attached through general primary care, and how many are losing a physician due to retirement or other reasons, and patients that expire and so on. So there is an ebb and flow, but yes, those numbers are not double counted as it pertains to the notion of unattached.
Follow-up, Councillor Nicholson.
Yeah, thank you, Chair. No, and I just wanted to make sure I understood those numbers relative to each other. I still applaud the IVC initiative, and at no point in time would I ever suggest taking our foot off that pedal, pedal to the metal. It just reinforces that we're not going to solve the problem through IVC. We're just basically trying to manage the existing numbers. So there's still work to be done. Thank you.
Yeah, thank you, Councillor Nicholson. I think it is prima facie there this is multi-vector, the response. I do know that the province has, I believe, committed towards increasing the number of spots in medical schools as well. So it is going to take a myriad number of approaches that's going to begin to address this issue. The other item, and I will open it up to all of committee as well. But the other item that I was quite interested was the VTAC numbers, which is kind of the top chart, which shows the 3 months. And I just picked March unto itself. So of the reception triage, 5,621, and 57% of those actually were connected with a VTAC physician. 43% of those presumably did not require that, or perhaps were advised to go directly to Emerge. I cannot know that. But ultimately, I think that once again demonstrates the diversion that VTAC is able to do, and how it is also contributing towards relieving some of the strain on waiting times, et cetera, at emergency, because again, the snapshot in time, but if 43% is a reasonable estimate, even if we downgrade that to say 33, 1 in 3 of the people that are phoning VTAC that do not need anything further, but also are not showing up at emergency rooms as well. So there is a substantial benefit being felt in the health system that ultimately VTAC is providing through the services that it provides as well. Anything further on any of the items, any of the charting on item number 5? Again, numbers. Who doesn't love numbers? Chief Nolan.
If I could, you'd asked some questions there that may have been rhetorical, but we know our numbers are less than 2% of the people that call VTAC are asked to hang up, call 911, or go to the Emerge. So it is a very, very small number, and we can compare that to any other telephone medical service that the province provides. Their numbers are significantly higher. So part of the reason that VTAC is so successful is that we're providing the right service the first time. And that's why it's actually difficult when you compare the cost of VTAC to a family health team versus the cost of VTAC to 811 or Rocket Docs, or the cost of VTAC to an urgent care center, or the cost of VTAC to an emergency department. And those that are naysaying VTAC would say, oh, it's expensive. But what is it expensive compared to? An emergency department visit saved? No, it's an exceptionally efficient program and has high cost effectiveness. When you compare it to 811 or some other services that have very high referral to ED and 911 rates, it's still highly effective. But we have to be cautious as to how we compare it. The difference between those that call VTAC and those that get an appointment with either the paramedics or the physicians are managed by our medical receptionists. And so they have become expert health system navigators. They say, why are you calling today and what do you need? Oh, did you know you can go to your pharmacy? Because the pharmacist now has the ability to prescribe that. Did you know that there's a 1-800 number for mental health crisis in children? Did you know that there is a pop-up clinic at this place, 2 weeks from now? Would you like us to make a reservation for you so that you can address, your gender-based issues? So those are all of the touch points, but every one of those touch points is still a service. It's just not measured in the same way the physician contact and the paramedic contact is. It's the delta between the three.
Yeah, well, there's something that I had not even considered. The system navigation unto itself has become so complex now, and the ability to have that resource through here. And ultimately, what you just described seems that it is self-evident now what the expectations should be of these systems, because this seems to be in almost complete alignment with the medical priority dispatch also, as the approach that it is taking, so too is that the approach that we are facilitating through VTAC as well. Everyone that has a medical issue does not necessarily need a full engagement of the system. So thank you very much for providing that. Moving on then to item number 6, questions, comments. I'll start. I think that perhaps the selflessness, the generosity of spirit of Mr. Blackstein may only be matched or surpassed in his humility. I don't know anyone that is as self-effacing as Fred Blackstein, who must find it challenging to always be leading from the shadows, because that seems to be his preferred spot, is to always be in the background in the photos. This is an incredible gesture, though with my knowledge of Mr. Blackstein, not shocked, frankly, at this generous offer. Again, as I'm sure committee and council and those who may be watching this may be aware, Mr. Blackstein's Order of Canada is actually in the lobby of this chamber right now. So very pleased to this, and an enormous appreciation to Mr. Fred Blackstein. I think perhaps Warden Emo, were you raising your hand?
Yes, again, thank you to Fred for his gesture. It was quite generous, and as always, he couldn't understand the public fuss over his gesture. Also like to thank the City of Pembroke. They did an excellent job as the host of the event. And to thank our first responders. That day there were the paramedics, the fire department, various fire services, the OPP were there, as well as the armed forces. And so, there was a lot of conversation and kudos to the first responders, because we do recognize and should recognize the time that they spend perfecting their craft, but also the cost of that in terms of the hours, the stress, the working with equipment, and sometimes we're not always as quick as we could be to replace that equipment or ensure that it's as good as it should be. And then I think what was inadvertently omitted that day was to thank the families of the first responders, because there's a lot of missed birthdays or late appearances at hockey games or basketball games, or maybe the grass is a bit longer than it should be at home. And so I think, while we're talking about first responders, we need also to recognize the contribution of their family, not just their spouses, but their children and their parents and brothers and sisters who are supportive of them and quite proud of their efforts and contribution to the community. So a great day. Many thanks to Fred, who, as I said, was somewhat bemused and a bit befuddled at the outpouring of affection and respect for him.
It would not surprise me if Fred, in fact, would have been quite happy if we just handed him the new signs and a ratchet, and just all on his own, he just went and changed all of the signage, because that is certainly the Fred Blackstein that I have come to know. So thank you for that. Anything further? Councillor Lafreniere.
I just want to say, on behalf of the city, for me personally, it was almost a no-brainer when he came and proposed that we change the name. I mean, especially since we put that water fixture down there now, it all just sort of plays in together, that we definitely identify and recognize our first responders. And I want to say that there was a tent set up down there, and it was just not even a tent, just one of those little covers. And the wind took it, but we had enough first responders there. If somebody would have been injured, we were covered. But no, it was a great day, a little windy, but I want to thank all our first responders again for everything they do. Thank you.
Thank you so much, Councillor Lafreniere. Moving on then to item number 7, the rehabilitation facility resolution. Item 8, the research, both IVC and the Penthrogs.
Excuse me.
Sorry, Warden Emo.
Yes, thank you very much to the city for initiating this this resolution and a pathway towards a service enhancement for our communities. I should note that I believe Dr. Morgenstern, with his initiative, one of the subtables or one of the subcommittees, I think, will be talking about services. So it's a very timely motion, and in answer to a partial answer, I think to Mayor Murphy. I don't think we have to focus on PRH because I think the eventual service, should it be established, will likely be closer to the Ottawa, Lanark County area, because I think it's going to have to service a larger area to have enough clients to keep it in existence, and it may have to start as a semi-private or a fee-for-service facility, and so you'll need a large number of clients. And I hate to say it that way, because unfortunately we're at a point in our evolution of funding services where it has to be a volume or at least an ability to demonstrate you have the right volume to ensure continually. But I'm so glad that the city has started the conversation, and there are lots of people in the community who are interested in this, and I hope we can gather them under the umbrella. Thank you.
Thank you. Back to number 8, either of the research initiatives. Item 9, Guardian Angel nomination. Want to extend appreciation both to the nominator and also to the advanced care paramedic Aaron O'Reilly Olszewski and Wade McPherson. Very pleased at the nomination and certainly pulling for them. Back to you then for resolutions, please, Chief.
Item number 10, recommendation that the Health Committee recommend, after a review of the current state of emergency service paramedic service issues, staff submit delegation requests at the upcoming Association of Municipalities of Ontario conference that are consistent with the 2023 to 2026 County of Renfrew strategic plan, current initiatives that require full advocacy, and previous delegations that addressed funding shortfalls.
Could I have a mover, please? Councillor Purcell, seconded by Councillor Weir. Background, please.
Thank you, Mr. Chair. Through you to members of committee. The background is that staff are reviewing all options within the emergency service paramedic scope that may submit a request to have a delegation at the upcoming Association of Municipalities conference, including the following potential requests: that of the Minister of Health, Minister of Colleges and Universities, Minister of Long-Term Care, as well the President of the Treasury Board, Minister of Finance, Associate Minister of Housing, and any other issues that may arise, Mr. Chair.
Thank you. As I had noted earlier when we were discussing MESA, I think one, just to add to this, and I know that this said including, the resolution said including these, but I added in that I think would be a key, would be the Associate Minister of Mental Health and Addictions as well, which is Minister Michael Tebolo. I think we would add to that, to the roster, and then hope that we are not successful on all of them. Anything further on this? Seeing none, all in favor? That is carried. Thank you. Moving on to bylaws then, please, Chief.
Recommendation that the Health Committee recommend the County Council adopt a bylaw authorizing the Warden and CAO Clerk to sign a contract renewal with 211 Ontario to provide 211 contact center telephony system access and support the Renfrew County Virtual Triage and Assessment Center team.
Could I have a mover, please? Councillor Murphy, seconded Councillor Grills. Background.
The purpose of this MOU between 211 and the County of Renfrew is to provide 211 contact center telephony system access and support for the RCBTAC program from April 1, 2024 to March 31, 25 at the amount of $30,000 plus HST. As attached as ES5 is a memorandum of understanding, Mr. Chair.
Thank you. Questions, comments? Warden Emo.
Thank you. I think the 211 system is invaluable, and this helps certainly to establish it as a community resource. And I've had some conversations with them recently, and we're going to be likely they'll be petitioning for an opportunity to make a presentation to us, and we're also discussing means of getting it out there so that people look to 211 to try and find community resources. So they've worked hard at updating the resource list in the county. It's being maintained, I believe, by the Killaloe Resource Center to ensure that it's current for the county. the county as a community. So we'll hear more about it, but I'm glad we're utilizing them as well as many other means of getting our services known.
Thank you. Any further question or comment? Seeing none, all in favor? That is likewise carried. On to item 12, please, Chief.
Through you, Mr. Chair, to members of committee, that the Health Committee recommend the County Council adopt a bylaw authorizing the Warden and CAO Deputy Clerk to sign a lease agreement between the County of Renfrew and Care for Health and Community Services.
Mover, please. Councillor Lafreniere, seconded by Warden Emo. Background.
Attached as Appendix ES6 is a lease agreement between the County of Renfrew and Care for Health and Community Services and a tenancy agreement for the County of Renfrew VTAC program at 425 Cecilia Street for a one-year term for the lease at that location, and the rent is payable on or before the first day of each month with an option to renew, exercisable by written notice prior to the end of the term, Mr. Chair.
Thank you. Questions or comments, committee? I see none. All in favor? That is carried. And that concludes the Emergency Services Report. Could I have a motion to approve the report as a whole, please? Councillor Lafreniere, seconded by Councillor Grills. All in favor? That is carried. Thank you. It is 11:06. We will take a brief recess at 11:15. We will reconvene for the long-term care report, please. Welcome back, everyone. And we left off concluding the emergency services report. I would invite Mr. Blackmore, Director of Long-Term Care, to take us through the long-term care report. Mr. Blackmore, the floor is yours.
Thank you, Mr. Chair. Through you to committee. Item number 1 is the Treasurer's Report for March 2024 for each of Bonnechere Manor and Miramichi Lodge, with Bonnechere Manor starting on page 34. Of greatest significance, as you can see, is we're significantly underspent in salaries, approximately $1.16 million at the Manor, for which about $900,000 of that is offset by purchase services for staffing agencies and accommodations. And on page 41, similarly for the Lodge, you can see an underspend of about $290,000 in direct care. And as was explained in previous committees, this is largely due to staffing challenges, recruiting that, that essentially all of long-term care and healthcare in general is faced with. But pleased to report that since December, on that front, the Manor has realized an increase from 3.05 hours of care per resident per day to 3.14. And Miramichi Lodge has realized an increase of 3.42 hours of resident care per day to 3.59. And recruiting efforts continue. We'll be looking at entering into our next wave of recruiting and adding to the master schedules. Item number 2 is long-term care resident statistics. The first 2 tables detail bed vacancies for each of the county homes for the period February 2024 to April 2024. Also included, the tables below include the wait lists for County of Renfrew long-term care homes. At present, there are 773 applicants awaiting placement and 220 in long-term care seeking transfer to their first choice of home, totaling 993 applicants. This time last year, that number was 839, so an increase of 154 on the wait list. And committee will recall that at the February report, we reported that approximately 60 of those residents were crisis residents, of which 20 were residing at home, 20 residing in retirement, and 20 residing in another hospital, of which about 55% of those crisis applicants are being cared for by our Renfrew County Paramedicine Services. And I would think that of that 55%, likely that's not including those that are in hospital. Item number 3 is the 2024-25 case mix index funding for the Manor and the Lodge. Committee will recall that CMI funding is based on care acuity levels for all residents that live in the home over a 1-year period. The care acuity level for each resident is categorized and fiscally weighted in what are called resource utilization groups, or RUGs, and my apologies for the acronyms. These RUGs, they collectively determine the CMI percentage that each home is entitled to. And what we're seeing here for this year is an end result higher than we'd anticipated of $489,300 for the Manor and $452,100 for the Lodge. That was unexpected. And I think what we'll have to do there in terms of budgeting, we'll have to go back, dive into this a little further, because typically we're a little closer with regard to estimating what our CMI is going to be. So I think we'll have to go back and look at that to see what happened there. The good news is it's to the positive. Number 4 advises a 2.5 increase to the basic and private accommodation rates as decreed by the Ministry effective July 1, 2024. And this is the portion of funding that represents the fees paid by the residents. As is indicated in long-term care 2, basically there's 2 parts to this formula. It's based on whatever the CPI was, which was 3.91, but at the same time it can't exceed 2.5. So 2.5 is the ceiling and 2.5 is what we're awarded coming as in terms of an increase effective July 1. Item number 5 is a public health inspection conducted by RCDHU at Bonnechere Manor on April 30th. And kudos to Food Services Supervisor Kayla McNulty and her team for an infraction for report as detailed in Long-Term Care 3. For item number 6, very pleased to report that earlier this month, Miramichi Lodge received notice of our Butterfly Model of Care audit, receiving an outstanding rating, one of 4 homes in Canada awarded this designation. It's been a long program since the program was paused by COVID, but thank you to all the staff managers who put many hours of work into the programs. As expressed by Meaningful Care Matters, their commitment to, and dedication to continue to exemplify what it is to be a family home. And thank you to elected officials for your continued support in the program. In terms of what's next, we are looking at putting together a video. Hopefully we have it ready for the June Health Committee to view. And you'll see later on in the report, we're hoping to get you on site in August for Health Committee report. Item number 7 recognizes the changing of the guard for Environmental Services Supervisor at Miramichi Lodge. Our former maintenance worker, Matt Ramus, was a successful applicant. Very pleased to see this as part of our very successful succession planning. Matt's going to be a great benefit to our home. And thank you very much to Daryl Berger, Environmental Service Supervisor, who came back out of retirement and is about to enjoy his second retirement. So thank you so much to Daryl. And resolutions is next, Chair.
Thank you very much, Mr. Blackmore. We'll go back to information item number 1, the Treasurer's Report. Any questions or comments? Just a couple that I have, and they're kind of oddities, at least from my perspective they are. The first is on page 37 of the PDF report, and it is the Adult Day Program. And about 2/3, 3/4 of the way down is provincial subsidy operating. And the full year budget shows that we didn't budget anything, and we got almost $240,000.
Through you, Chair, I'm looking to my esteemed colleague, Mr. Daniel Burke, to he may respond to this.
Thank you, Chair. The Adult Day Program has been somewhat of an oddity. Committee will recall this program is run by Bonnechere Manor, and it's historically never been budgeted for at all. You'll note that there's no budget in any of the lines. It's also never been displayed on the face of the Treasurer's Report for Bonnechere Manor. It's always been in the back pages that you'll be unfamiliar with, sort of left off to the side. And so in this instance, my aim is to include it as I would any other department or program that runs under the umbrella of the County of Renfrew. And going forward, we would budget for it and have reporting on it, as you see here.
So this is not new money. It has previously been recognized integral to the manor overall. Is that correct?
That is correct. The program has been running for a number of years now. It is a fully funded program, so it's dollar for dollar provincial money. But I'm not certain when it started, but it's been ongoing for a number of years.
It's been going at least as long as I've been here, and I'm not sure which of the saws that is, LSAW, MSAW, one of those saws. In any event, so that certainly jumped out that I was wondering, a la Milton Wadhams from Office Space, that we just had staff kept showing up to work, even though we don't actually have a budget. Anyway, thank you for the explanation, Mr. Burke. The other one was on page 39, and I had opportunity just to give the heads up to Mr. Blackmore. So on other revenue fit, and that is the feed-in tariff, that is the solar generation. And you'll note that year to date is $961, and either there's something wrong with the number or there's something wrong with the solar units or the technology. And the reason I have an insight into this, I also have solar generation along Highway 60 at Douglas. Now there is somewhat of a difference between my solar generation and the manor. The manor is static on the southern facing, well maybe on all of the roof, but certainly on the southern facing. Where mine are trackers. But my expectation, the expectation of revenue here is $110,000, and mine is probably about 75. And I'm getting about 12.5% of my revenues, my electrical generation, and subsequently my revenues are happening in the first quarter, and $961 cannot possibly be accurate unless there is a technical problem with the units or there is some error introduced into the revenues. that number cannot be accurate. So I don't expect that anyone will have the answer to that today. I just had opportunity to broach that with Mr. Blackmore earlier this morning. But if we could just check into that, I can't conceive that we have to earn $109,000 over the rest of the year, that we only generated $1,000 in the first quarter. That's it for me for the budget, other than I know it is only the Q1 report, but bear with me one moment. Yeah, right now it looks like a municipal surplus of $2.5 million in long-term care. I know that we have a lot of the year to go yet, but certainly that's encouraging. Back to you then, Mr. Blackmore. Oh, sorry, we're reviewing these. The resident statistics, the long-term care resident statistics. Questions, comments? See none. Item 3, the Ministry of Long-Term Care funding on the CMI. I'm just wondering, both on this item and the next one, item number 4, either to Mr. Blackmore or through you perhaps to Mr. Burke. In each of these, so I believe under the CMI, this item number 3, that these were unanticipated, unbudgeted revenues that are now becoming available, augmentation to what we had normally received. Is that correct?
Through you, Chair. Yes, that would be correct. So we had made an estimated budget of our CMI where we expected that to land, and it has actually come in significantly above what we had thought. So that would become a multiplier through a number of the operating subsidies, which will then drive out more revenue. None of that would have been apparent on the last Treasurer's report, as the CMI is a ministry year, so it kicks in April 1st, the new ratings.
Okay, thank you. And there's also then, of course, the confusion would be compounded in that only 3/4 of those dollars would be recognized in 2024, and in fact, the provincial fiscal Q4 is outside of our 2024. But I agree with you, the total dollars is $941,000. I think we can all agree that that's a significant number. Moving on to item 4, the long-term care home accommodation charges. I'll repeat the question again. Is this already written into our budget? Did we anticipate some increase to the accommodation charges, or will this be somewhat augmenting what we had budgeted?
Through you, Chair. So the accommodation charges are sort of an odd animal in that we don't actually get to keep them, except in the case of preferred accommodation. So that's really the only one that matters to us. Otherwise, the regular accommodation is actually an offset to the funding formula. So the more we take in from the residents, the more provincial dollars we give back, I'll say it like that. So no, we didn't budget an increase, I don't believe. I'll have to go back and check my notes, but I don't believe we did. But again, the only one that really matters to us is the preferred accommodation charges.
Okay, thank you. And so as I understand it, the more that the tenant, if you will, is contributing, then the less is provided from the province. So I'm assuming that we share somewhat in that as a partial share of the funding. With respect to the what we had anticipated for resident revenue, I did go back to the consolidated budget to take a look at that. And there are substantial increases already were written into 2024 from 2023. At the Manor basic accommodation, we anticipated a 7.8% increase, and on preferred, a 36.7% increase, which seemed astonishingly high. But I'm wondering if that is based on utilization, perhaps as much as what the rates themselves might be. I know that the Manor is similar, though, that the lodge is similar, though the preferred accommodation is much lower. The total resident revenue at the Manor was forecast to increase 11.3%, and at the lodge, 4.1%.
Through you, Chair, I believe that issue was when we were in the COVID era, we really couldn't collect on our preferred charges. I think the directive was that we had to fill those rooms, or there was a directive there anyways. For a long time, we weren't collecting any preferred revenue, or very minimal. And now, as we move out of the COVID era, we've begun, and I believe that's where we had 2013, we had budgeted significantly reduced preferred revenue fees, and now we're just coming back up to the prior level that we were seeing before COVID. So I'm not sure that it's I think that's a post-COVID adjustment more than an expectation of more occupancy.
I will be back here tomorrow morning for Finance and Administration, so as to not put you on the spot as I'm reviewing this also, and this is from the consolidated, well, actually this is from the Lodge component to the 2024 budget. In fact, just to add one more level of complication, preferred accommodation is anticipated to go down by 3.3% at budget. So I will defer, and perhaps tomorrow at Finance and Administration, you can make me aware of what the differences will be. At the Manor, it is substantially up. At the Lodge, it is relatively down. Anyway, thank you for that. Mr. Blackmore.
Just a comment insofar as utilization is concerned. As far as the ministry is concerned with regard to funding, it's that we maintain a 97%. It's not on a per bed basis.
Okay, thank you. And I do know that that was set aside through COVID because there were some enormous challenges as we were responding to COVID, to IPAC, et cetera. Thank you. So thank you. We'll defer that to tomorrow. Item number 5, the health unit inspection at the Manor. Certainly going to echo Mr. Blackmore's comments on Ms. McNulty, the food services supervisor, on the clean inspection. Item number 6, the butterfly accreditation. Oh, sorry, is this on item 6 or 5, Councillor Murphy? 6, okay. Item 6, the butterfly accreditation, please.
Thank you, Chair, and through you, congratulations on this. I feel like it's been a long time since we went to Milton to see the butterfly model, and it's so lovely that it's installed now in the home and that you received this designation of outstanding. So congratulations to you and Ms. Neal and everybody that was part of, well, I guess she was the accreditor, but all the people that were involved in creating the butterfly model at the Lodge. Thank you.
Thank you, Councillor Murphy. Anything further? I believe it's 5 years. I think it was in October of 2019, perhaps, when the bus trip to Milton Village occurred. There was a couple of things got in the way since then. Item number 7, the management team at Miramichi Lodge. Congratulations both to Mr. Berger and to incoming Mr. Ramus. And how many retirements do we afford any of our departing staff? Will we expect them back once or twice still? Or is this a finality, do we anticipate? In any event, congratulations for a very, very long and dedicated career from Mr. Berger. Moving on to resolutions, then, please, Mr. Blackmore.
Thank you, Chair. Through the committee. Resolution number 8, Association of Municipalities of Ontario Delegation Form. A recommendation that the Health Committee recommends that after a review of the current state of long-term care issues, staff submit delegation requests at the upcoming Association of Municipalities of Ontario Conference that are consistent with the 2023-2026 County of Renfrew Strategic Plan, current initiatives that require further advocacy, and previous delegations that address funding shortfalls.
Thank you. Could I have a mover, please? Councillor Grills, seconded by Councillor Weir. Background, please, Mr. Blackmore.
Thank you, Chair. Through the committee, background, staff is reviewing all options within the long-term care scope and may submit a request to have a delegation at the upcoming Association of Municipalities of Ontario Conference.
Thank you. Any questions or comments? Seeing none, all in favor? That is carried, and I do believe that that concludes the long-term care report. I'd seek a motion to accept the report as a whole, please. Councillor Purcell, seconded by Councillor Wilmer. Any further questions on any item on the long-term care report? I see none. All in favor? That is carried. Administration report can be found on page 53. Mr. Kelly, I will yield the floor.
Thank you, Chair. Item number 1 of my report is just an information item, as I do have delegated authority from Council from a few months ago to sign agreements for an Ontario Health Team, at least the Warden and I do. This is a funding agreement that extends funding to the OVOHT for the next couple of years, about $750,000 per year. So again, this will be signed with that authority, and I will pause there for questions.
Thank you. Any questions on the sole information item on the Administration Reports Committee? Seeing none, back to you, Mr. Kelly, please.
Thank you. The recommendation stemming from item number 2 is to hold the August Health Committee in a different location, and the recommendation would be that the August 2024 meeting of the Health Committee be held at Miramichi Lodge.
Thank you. I would now seek a mover, please. Councillor Lafreniere, seconded by Councillor Nicholson. Background, please.
No, thank you. So as Mr. Blackmore rightfully said, is that it would be a pleasure to go see the butterfly model of care in person and meet the staff that's been involved there. It's always been a pleasure to host meetings in our own facilities on occasion, and Miramichi Lodge, of course, is one of our great locations that we have throughout the county. So we would ask that, and we are asking that this committee meet. I believe that we will also have the same resolution at Community Services, so we will spend the day there, and you will be obliged, I guess, by the wonderful staff at the Food Services who provide us with lunch that day as well. So there you are.
Thank you, Mr. Kelly. I note, interestingly, per our procedural bylaw, that every member of committee has veto power.
Yeah, you guys wrote that procedural bylaw.
We can always be trusted to do the right thing, can't we?
You are.
Not just a supermajority, 100%. Councillor Weir.
Just questioning for the public, is there access to video on that day as well?
Through you, Chair, yes, that's part of the technology, and that's why we need the 60-day notice to make sure that we will be doing that. But the meetings will not be closed; they will still be accessed. Whether they're technically available that moment or not, we'll still have to figure that out. But they will be available on YouTube shortly thereafter, if not available live.
Thank you, Mr. Kelly. And just before I call the vote, just do keep in mind, I am very much in favor of this. If there is any member of committee disinclined, do recall who it is that recognizes question opportunities when we are in committee, and that shall be taken into consideration. With that, I will call the vote, and I need to see it unanimously. All in favor? It is unanimous. Thank you. That does, I believe, conclude the Administration Department report. I would seek a motion to accept it in its entirety, please. Councillor Weir, seconded by Councillor Murphy. All in favor? That is carried. Thank you. There are no Board of Health minutes at this time. Is there any new business? I see none. There was no closed meeting requirement at time of mailing. Is there any need for one, Mr. Kelly?
There is not.
Thank you. Our next meeting shall be Wednesday, June 12th, 2024. I would seek a motion to adjourn, please. Councillor Purcell, seconded by Councillor Wilmer. All in favor? Carried.